Hi, Mary Jane.
Hello, Maria. How are you?
I'm fine. Happy Thursday evening, and thank you so much for spending some time so we can talk tonight on this episode of Gynecology, which is the Women's Healthcare of Princeton live stream show talking about lots of different aspects of women's health. I really appreciate you coming tonight.
Thank you for the kind invitation. Always lovely to visit.
I agree. It's nice to see you too. For those of you who don't know, my guest tonight is Dr. Mary Jane Minkin. Mary Jane is a clinical professor of obstetrics, gynecology, and reproductive sciences at Yale Medical School. She's also the director of the Sexuality, Intimacy, and Menopause program at Yale. And it's my privilege and honor to know her. She's also a member of the Menopause Mafiosa, which is a very politically incorrect group of wonderful, wonderful women who share thoughts and ideas about women's health and also a lot of laughs together. And I love having her as a mentor, a colleague, a friend. And she's witty, she's engaging, she's smart, she's sassy, and she's just downright fun to listen to. But besides that, very importantly, she's also from East Brunswick, New Jersey. Who knew? So I'm broadcasting from Princeton, which is, the uppity hoity-toity part, but she's much more grounded than I am. So, there's a show called Mayor of Easttown, right? Have you heard this? Mayor of Easttown.
Yes, I've seen some episodes, yes.
Okay, so that's from the Philly suburbs, kind of near where I grew up, also not the great side of the tracks. And you're sort of my mayor from East Brunswick. So
that's what I am.
I know. I thought that was pretty funny. Tonight we're talking about something I think near and dear to both our hearts. As OBGYNs, we deal with women of all different ages, and some of those women, sadly, are cancer survivors, or happily, I guess, are cancer survivors. And we are both old enough to have trained in times when a cancer diagnosis implied infertility, sterility, and a shortened lifespan. And happily, many cancers now are so treatable, and women go on to live very full, robust lives. And so I think we both believe that women who have cancer should not be just thought of as a cancer patient, but as a full-fledged woman who has needs of sexuality and intimacy, who may want to have children. And I thought tonight we could share a couple stories of patients, and you could help our listeners understand what opportunities and options women who are cancer survivors have. Does that sound like a good program?
Sure.
So
absolutely sounds terrific. And
okay, we're going to
go talk about these issues, and then.
Yeah, you're a little delayed, but we're going to go kind of chronologically. I had a patient today who was 25, and she has a recent diagnosis of Hodgkin's. She was very actually optimistic about the fact that she's going to undergo chemo. And she said to me, look, if I have to have a cancer, this is a good one to have. I'm going to have my chemo, and she's newly married, and she hopes to have kids. So what kind of advice could you give her before her chemo? How should she be thinking of her own fertility and the sanctity of her eggs between now and when she has her chemo and afterwards?
Absolutely. And the answer is, you're absolutely right, Maria, that she should be cured. I mean, she should do quite well. But the key thing is, unfortunately, with most of the chemo, or many of the chemos that are given these days, they can render people infertile, unfortunately. Yeah. But that's the bad news. The good news is that we can now save eggs before somebody gets chemotherapy. And the key thing is, most people, and maybe this is the most important thing we can clarify, that if you get a cancer diagnosis, it does not mean you have to start therapy the next day or you're going to die. Okay, that we have plenty of time in general to get some eggs out of a woman, okay, and preserve her fertility, because we can save these eggs. Now, again, the other good news is 10 years ago even, that we couldn't save an egg. We had to save an embryo. So they had to be a woman who was in a partnered situation that we get her eggs out and basically get them fertilized by her partner's sperm, save them, freeze them and stuff like that. And then you could plant in frozen embryos after she was cured of her cancer. But it was really tricky if somebody wasn't in a partnered situation, so that you wouldn't be able to save her eggs. But now we can. And the techniques are very excellent these days for saving eggs. So if a young woman is in a situation, she's very young, she's very young and is not partnered, does not have somebody, the partner of her dreams, in her life yet, but her eggs can do that quite well. And we can get out a bunch of eggs before she undergoes the chemotherapy. These eggs can be saved. And then when she selects a partner in life, that they can be fertilized with his sperm and that she can go ahead and have a baby. And that's what we really hope to see. And somebody in this category is an ideal candidate for that. We knew for years that you could save sperm from guys, but this was not a well-known thing until the last really 10 years that you could save eggs isolated, not in an embryo state, for women. So this is a real achievement. And again, the key thing is, if you know somebody who's a young woman just having had this cancer diagnosis, really, and again, her parents, her family are going to be crazed. She's got to go see the chemotherapy doctors tomorrow to save her life. No, you have time. Get her hooked up with a real reproductive endocrinologist who works with oncologists so that we can save her fertility. And that's a really important thing to do.
Okay. And that's probably at a university setting, to have a team like that. Is that, or are there community reproductive endocrinologists?
Well, we certainly, yes, every setting, every major university center in the country has it. But the other thing is, you can always, if you're saying, gee, I'm out in the middle of nowhere, there's no medical centers nearby. First of all, if you have an oncologist there, a good oncologist is going to know the reproductive endocrinology people. But there is something called SART, and you can go to Society of Assisted Reproductive Technology.org, and you can look on the website and you can get a list of very certified reproductive endocrinology people who can do these egg retrieval procedures. So if you say, gee, I really don't have any resources nearby, my oncologist doesn't know anybody, go to SART.org and you can find people.
Easy. I know. And with the web, things are
Easy.
one click away.
Easy.
It's really neat. So
Yep.
That was one patient I had, but I had another patient who had also Hodgkin's, but she had it 7 years ago, and she's free, she's clear. She had her chemo. She is on with her life. She's married. Her career is taking off, and she is talking about starting a family in the next few years. But she has some concerns. She's a little afraid because once you have cancer, you always keep that in the back of your mind. You always worry the cancer will come back. Or what if it comes back while I'm pregnant? Or what if the pregnancy somehow causes the cancer to restart or recur? What can we say to her, this patient with Hodgkin's, about what she needs to know about herself during pregnancy, her risk of getting the Hodgkin's back? Will the pregnancy somehow affect the cancer risk, or vice versa? And what about other cancers?
That's another excellent question. Yeah, it's another excellent question. And indeed, people with Hodgkin's should do very, very well in a subsequent pregnancy. If they're cured of disease at this point. I mean, anybody can always get a recurrence of a tumor, unfortunately. But if she's been out 7 years and she's clear, she should do well. She should be fine. And the other key thing to remember is many, many, many tumors in this world are not sensitive to estrogen, or the hormones of a pregnancy. And Hodgkin's disease is one of them. So that she should have no concerns about pregnancy accelerating any recurrence of disease or anything like that, and she rates to do well. Now, the only issue is if she's somebody who had eggs saved, then she's great. Just get them implanted. She should do fine. And the other thing is, she may not have had her fertility totally taken away by chemotherapy, if that's what she had, because she may have some ovarian function at this point. So she may do well without having had eggs taken from her in the first place.
Okay, and that's an easy blood test. People should know that they don't have to fear that if they didn't do the egg retrieval, all is lost. They can certainly at least check their AMH.
No, absolutely.
Yeah, and see that.
Exactly. There are tests for fertility afterwards, and she may have retained fertility, and that's fine. So, as I said, if they didn't get eggs from her, she has still a good chance of getting pregnant. If she's having regular periods, she's probably got a good chance of getting pregnant.
Right. And actually, even if her fertility is totally wiped out and she did not do the retrieval, there are donor eggs available. I mean,
Absolutely. And she could have a donor egg, and that's entirely possible. And she would be a good candidate for it. Again, if she's a healthy young woman, which she is. I mean, the previous diagnosis of Hodgkin's does not make her an unhealthy person, and she should do well.
so you mentioned that some cancers are hormonally dependent or hormonally affected. Let's just talk about which ones those are, so that we can address
Sure.
those women as well.
Sure. The major tumors out there that are estrogen sensitive are indeed breast cancers. Now, again, the other key thing that I want to get across, and this is maybe an advertisement on my part for hormone replacement therapy, that estrogen does not cause breast cancer. Okay. So if somebody has what's called an estrogen receptor positive, I'm sorry?
I said, I think we need to say that again about
That
10 times. Yeah.
Yeah, I will say it several times.
Okay.
Estrogen does not cause breast cancer. That the key thing is that even if somebody gets it, some patients will say to me, no, I had an estrogen receptor positive tumor. That meant that estrogen caused it. The answer is no. It just means it is sensitive to estrogen. Estrogen can promote its growth. That's absolutely correct. But it probably, as far as causation, it probably did not cause it. It can promote its growth. So the key thing is that if somebody has an estrogen receptor positive tumor, most oncologists have some concerns about pregnancy in these women. Okay. Now, does that mean they can't have a baby? No, not at all. Okay. So what many folks will do if they do have an estrogen receptor positive tumor, their oncologist will want to make sure that they're clear of cancer. Okay. And many women will be absolutely cured of an early cancer, stage 1A cancer. Women should be cured. These days, the statistics are excellent. So if she's cured and she's now gone several years without without any evidence of recurrence and stuff like that, she will rate to do well. And most oncologists will say, yeah, go for it. Go have a baby and you should be able to do fine. So indeed, estrogen, as I said, breast cancer is one of them. I see we have on the screen uterine cancers. Uterine cancers can be estrogen receptor positive. Fortunately, they're fairly rare in young people of reproductive ages. So, it can happen, but it's not a super common one. The most common one we see is breast cancer. The majority of cancers, although we see in young women, are not. And for example, one example, which I think is really interesting, and this has evolved certainly in my lifetime, that basically that if a woman has a cancer of her cervix, even a cancer that's not a simple in situ cancer, but she has even a little more invasive cancer of her cervix, we can actually operate on her cervix, take out the cancer, and we can leave her uterus in place. And we sometimes put a little stitch in to keep the baby inside the uterus without a cervix there, preventing it from coming out. But these women can then carry a pregnancy.
Yep.
Which is really remarkable. And, I've certainly, seen, several of these women, and they've done great. So, it takes a little bit of management, but this can happen. So even, having a significant part of your cervix taken out does not say you can't carry a pregnancy. So you can do pretty well. So again, there are very few cancers that things are out of the question of, no, you can't have a baby afterwards.
Right. Quick aside, speaking of cervical cancer, we don't typically think of it as estrogen dependent cancer. But if you have
it's not estrogen dependent. That is
correct. But if you have if you have an abnormal pap smear and you have a colposcopy and they do a biopsy and they say, oh, you have dysplasia, is that going to get worse during pregnancy? Should you have that treated before you get pregnant?
No.
So that's okay to wait,
No.
right?
I mean,
slow growing.
The answer is it's usually okay to wait. Cervical cancer is rarely. There are some cervical cancers called adenocarcinomas of the cervix, which are estrogen sensitive, but again, the vast majority are not. But can we make an advertisement? That's why everybody should have the HPV vaccine, because we want to minimize our risk of our young women getting cervical cancer. And this is a little unpaid political advertisement. But if you know a young lady who has not gotten her, we all talk about COVID vaccines, and that's extraordinarily important. But if you know a young lady who has not gotten her HPV vaccine, please ask her to get it, because we can now effectively prevent about 90% of cervical cancers. And that's remarkable. The old vaccine was pretty good, but that was preventing about 70%. Now with what they call the non-valent vaccine, which protects against 9 strains of nasty HPV, you can prevent about 90% of cervical cancer. So that's really terrific. So it's a little advertisement there.
No, important. It's never unwelcome in gynecology. And also, Mary Jane, I found fascinating the country of Australia, where they have almost 100% vaccination uptake. They have declared that by
Yep.
2025 they will have eradicated cervical cancer. We never talk like that
Yep.
in this country. Eradicating cancer.
No, no,
This is
we don't.
amazing. So
And it's fabulous.
yeah,
It's fabulous. And the boys can get the shots too, because unfortunately, and and the boys get something out of the deal too. You may say, well, they're just not concerned about not passing it on to young women. No, no,
right.
no. What the guys can get is that they can get pharyngeal cancers, which are really nasty. And so basically that you should get the boys and the girls vaccinated. They both need vaccinations.
I agree. And also,
So
it is so imperative that now it's paid for until age 46. This is insane that a childhood vaccine is now covered, that, insurance companies who don't really want to pay for anything will pay for this until age 46. If that doesn't tell you how the
exactly.
CDC has put
It's
appropriate
important.
pressure, it's a blessing,
Yeah,
really. So agreed,
it's
agreed, agreed.
important. It's important.
Sorry for that public service announcement, but you and I both
Public
feel,
service announcement.
yeah, that
We
was
have to do it.
exactly.
That's why we're friends.
Right. That one was for you, Joyce Verghese. Okay, so I'm
Okay.
happy to say that it sounds like cancer survivors do not need to fear that pregnancy is going to cause a recurrence of their cancer, or that or vice versa, that the cancer is going to affect the pregnancy negatively, as long as the cancer
Right.
is controlled, obviously. But there are
Yeah,
still,
of course.
let's be honest, there are still tricky timing decisions with a newly diagnosed cancer at the same time of pregnancy. Do you delay chemo? Do you delay radiation? So it's a challenging time if they coincide. But in a cancer survivor, someone
Yeah.
who has completed her cancer treatment, I think she should feel comfortable that she can be managed in a low risk, really, environment, that she's not necessarily
Right.
going to
You can
have
do
to
well.
worry about, yeah, that she'll do well. Um,
Right.
I think we need to, because it's such a short program, we need to kind of move on to women who are finished having babies now, and talking about women in menopause or perimenopause, where mood issues start to become a problem, where hot flashes, vasomotor symptoms start really affecting quality of life and happiness, and then eventually
Hmm.
urogenital issues kick in. And then this links
Yeah.
to the sexuality problems you and I have talked about. Some of these women have estrogen dependent cancers. I mean, breast cancer is a common cancer, in this country, right? One in
It
eight
is.
women, possibly
It is.
more. Um, Non-estrogen dependent cancers comprise lots of other cancers, right? Lung and colon and all kinds of things. So, what
Mhm.
are the options if I'm a perimenopausal patient and I come to your clinic and I say, I had estrogen receptor positive breast cancer, Dr. Minkin, and I am sweating all the time and I can't sleep because I'm drenching my sheets, and my husband claims I'm miserable and grouchy. What can you offer me? Because first, maybe let's start with, what can you offer non-estrogen dependent cancer women, because those women are getting the
Okay.
same thing as non-cancer survivors, right?
Right. And the key thing is that somebody who has a non-estrogen receptor positive tumor, basically, and again, the other thing to remember is the lung cancers out there, the colon cancers, the urethral, the urogyne type cancers, they all can be treated with estrogen. And those people can take systemic estrogens without a problem.
Right.
So the majority of folks, people who have leukemias, and as a matter of fact, certain people who've had bone marrow transplants, even as part of their hematological cancers, these women actually, especially, we want to be giving estrogen to for some peculiar reasons. So systemic estrogens, and we do. So that, there are many, many cancers that you can use, oral or patch forms of estrogens for these women who have non-estrogen sensitive tumors. But even for the ladies who have breast cancer, a couple of things. The most important thing to be aware of is that, and Maria alluded to this, women who have urogenital changes, dryness in the vagina, discomfort, bladder discomfort, things like that, that these women actually, even if they have an estrogen sensitive ER positive tumor of the breast actually can safely use vaginal estrogens in most cases. The amount of estrogen that's absorbed from the vagina is very small. And the North American Menopause Society, our organization, the American College of OBGYNs, both have issued position statements saying that women who have ER positive breast cancer, by and large, can use vaginal estrogen safely. So that's number one. We probably wouldn't give them, systemic estrogen, what we call, patches or pills, but we certainly can use vaginal estrogens. However, we're cautious about that. We have many fine products vaginally that can be used that are non-hormonal products for moisturization, which are quite popular, and they're good. And I just want to make one plug here, and we'll mention at the end, because we're not going to cover everything, obviously, today in the next 10 minutes, but please go to my exciting website, madamovary.com, and we have all sorts of videos and podcasts there for people to listen to get more of this education. So we got it all there. Don't worry. You can all get it. That's it. Very lovely. Thank you. So anyway, so we can do that. Now, as far as the people who say my breast cancer survivors, who are miserable with menopausal, perimenopausal symptoms. And the other thing to remember about breast cancer, not only may they be perimenopausal women going through menopause or already menopausal ladies, but unfortunately, many of the remedies we treat women with for who have ER positive cancers, breast cancer particularly, unfortunately can make hot flashes worse. Drugs like tamoxifen, unfortunately, can increase hot flashes. Drugs called aromatase inhibitors, unfortunately, can increase hot flashes, increase problems with vaginal dryness. So we have to deal with these people in this very special group of patients. But there are certainly some herbal products which are quite helpful, which are not estrogenic. Okay, a couple of the popular products out there. There's a medication called herbal product called Remifemin, Remifemin. It's a German black cohosh product. There's a product called Relizen, Relizen, which is a Swedish pollen extract, non-hormonal product, which can be quite effective for hot flashes for women in a non-estrogenic manner. So we use those a lot. Okay. The other option that we have is there are medications that have effects against hot flashes, which are not estrogen. Many women are not aware of that. And for example, the largest category of drugs out there are SSRI and some SNRI antidepressants, which can be reasonably effective as far as hot flashes. And hey, if some women are getting a little depression issues, because it's not cheerful having to deal with a cancer, that sometimes that these medications can be quite helpful, cheer up mood, and help with hot flashes. So that's certainly a possibility. Another drug that we actually talked about with a couple of our ladies, because today was my Cancer Clinic Ladies Day today, is particularly if somebody's getting like nerve pain, they've had some chemo that might give them a little neuropathy. A drug that's commonly used for that is called gabapentin. Neurontin is the trade name. And Neurontin happens to be very good for hot flashes. Gabapentin happens to be very good for hot flashes. So that's a drug. And I try to get two for a set of things. If somebody's got a little problem, I'll see if I can get two things for them. Not, therapy for their nerve pain and therapy for their hot flashes, or therapy for their mood and therapy for the hot flashes. So we do have a lot of options out there which can be used to effectively help with their hot flashes. And the other news, I'm going to use this as a teaser because this will get Maria to invite me back probably in the next year or two. There's a new drug that we all hope is coming out shortly, which is actually a very effective drug, because we don't even know the hot flash mechanism. I can't tell you about it, what happens. But we do know that one of the centers that controls it is our hypothalamus area. And that there is a drug that is very effective in the hypothalamus for women as far as taking care of hot flashes. It's totally non-hormonal, and I think it's going to be a great drug for my ladies when it becomes available, but I can't get it for you yet. But so I tell them there is hope with some new medications, but in the meanwhile, we have plenty of meds that we can use.
Yeah. So stay tuned. Hopefully next year we'll have part 2 of this, and we'll be able to tell. Do you have any idea when that's supposed to release?
My hope is I'm thinking possibly even within the next year. Certainly I would think within the next couple of years, but I'm hoping within the year that we'll be, at least seeing the signs that it's coming closer.
I mean, there are good things in the pipeline. And I think as the demographics of our country shifts and we have more women entering menopause, we have something like 60 million menopausal women now in the US, 500 million worldwide. And finally, some research and development money going into the biotech sector. I think, I do think the next decade is promising in terms of things out there for this cohort. What about oxybutynin? Do you ever use that, Mary Jane? Oxybutynin.
Oxybutynin is an interesting compound. That this is a drug that some of you may be familiar with who have overactive bladder. This is one of those drugs, so-called anticholinergic drugs, that helps keep people from going to the bathroom all the time. Like, I got to get there, I got to get there. But what it also does is has some anti-hot flash properties. So it certainly is a drug that we have in our armamentarium. And if somebody has, again, overactive bladder and has some hot flashes and can't take estrogen, well, I think that's a drug that we need to consider. And I have several people on it. Yeah.
Yeah, yeah. Now, are you allowed to say that one of our viewers wants to know, there's a comment, is do you know the name of the drug, the generic name or the chemical name of what's coming
Yeah,
out?
yeah. It's the name of it is called Fezolinetant. Okay, Fezolinetant. That's off the top of my head here. I do better writing it down. But the answer is it's finishing up phase 3 trials. The results have been promising, and we're just waiting to see it.
Yeah, yeah. Well, I'm sure everybody's kind of
TANT, TANT. Yeah.
not TAD, ANT, Fezolinetant. Okay. Yeah, yeah.
That's
So
it.
still in trials but some people are so hungry for something new, they'll look it up and try to get into the trial, which is fine. I mean, they try to get involved.
Well, I'd love patients of mine have been to get into the trials too, but I think the trials are pretty much winding down at this point.
Yeah,
Which
yeah.
there we go. There we go.
Yeah. So we'll cross
Now
fingers.
you can't quote me on will come out next year. I hope it will come out next year. I hope it will come out next year.
Exactly. And the FDA has been very busy with all kinds of other stuff in the last year. So, but those are all good options. And I think, what we're talking about here, just to be clear for everybody, is that for women without cancer and for women without estrogen dependent cancers, menopausal hormone replacement therapy, meaning estrogen and progesterone if you have a uterus, is perfectly safe. But if you choose not to, can't, won't, all of those women can also use remifemin or Relazin. They can use SSRIs or SNRIs, which are basically antidepressants. They can use gabapentin. In women with estrogen dependent cancers who can't or shouldn't or won't use estrogen, those non-estrogen options are good for systemic symptoms. Mary Jane mentioned, but I want to just reiterate that for local vaginal symptoms of menopause, dryness, burning, irritation, or recurrent UTIs, overactive bladder, all that stuff, genitourinary syndrome of menopause, those symptoms, you don't necessarily need systemic treatment. You can use local therapies. And even if you have an estrogen dependent cancer, you are safe to use that. It is, I have said it 1,000 times, and so many patients say, no, I'm sure it's dangerous. It's not. It's been studied in breast cancer patients, and never has it been shown to cause breast cancer de novo or cause a recurrence. This is vaginal estrogen I'm talking about. And then, of course, there are non-estrogen vaginal therapies too. Sorry, Mary Jane. I just wanted to make it clear that one thing you spoke about was systemic, but local estrogen therapies are actually pretty much safe for everyone.
I think that's good.
Yeah. I think it's
important. It is. Now, there is one group that I think that I need to make at least a few seconds, though, before we wind down. There's another special group of people out there, and we may have some viewers in this category. We aren't finding more people who are BRCA carriers these days who've had genetic testing. Indeed, turns out their mother has a BRCA dependent too, as BRCA positive, has a BRCA type breast cancer, something like that. And the young women are being tested and found to be BRCA positive. So many of these women are electing to have their ovaries taken out before they get to be too old, and they'll do this, even in young women of age 35. And the key thing to remember is that even if a young woman has her ovaries taken out, she's completed her childbearing, she's got her kids, she says, okay, time to get out my ovaries, that these young women do better if they're given estrogen replacement therapy. And I just wanted to mention that that these are young women, and if these young women are deprived of estrogen function, yeah, they're not going to get ovarian cancer, but they're also not going to do so good with their heart and their bones. And we have very good data there to show that if you give these young women, and we call them previvors, we call them women before they've not been diagnosed with cancer, okay, they're just having their ovaries taken out preventatively, because, some people call this the Angelina Jolie effect, that people who've had things done preventatively, and which is a good thing to do, but there is no reason those young women cannot take estrogen therapy. So I know these are some sounds like heretical thoughts that I'm spreading out there, but we do recommend estrogen therapy for those young women who have not been diagnosed with cancer, just or BRCA people, that we give them estrogen if they're very young women. So, and it's safe, so not to worry about that.
And I think the uptake, the willingness of these women to take this estrogen is going to be dependent on their clear understanding of what you just said, that for instance, I don't have family history of cancer. If I took my ovaries out early before menopause, I know it will help me to take estrogen so that my bones and my coronary arteries get that estrogen until I'm in my 50s, when naturally I no longer have it. But if you're 35 and you're BRCA positive and you get the ovaries removed preventatively, well, hooray, you're being super progressive, that super proactive. But that doesn't mean you can't take estrogen until you're 50, just so that your bones and your coronary arteries still get that benefit. And guess what? Heart disease is still the number one.
And people are blown away by that thought.
Yeah. Yeah. So you still want to not think.
We just don't. I just want to make sure that we planted that.
Yeah, I think so too. It's generally safe. It's safe. They should use it, I think, until 50. I mean, that's just a random figure, but at least until their bodies naturally would have had it. And they do well if they use it. And women who eschew that and fear the estrogen are going to be at risk for premature development of atherosclerosis and osteoporosis. And they're both killers in their own ways. They're both really, really
absolutely
causes of major morbidity and even mortality. So I think that can't be stressed enough. The fear of cancer and estrogen sometimes so outweighs the fear of cardiovascular disease or osteoporosis, which are silent. So I think we have to hammer that point home. You're 100% right on that. You're right. We could talk for another hour about this, but I'm so glad you brought up the BRCA carriers, because genetic testing is cheaper and more available now. So more people are getting it, which is good.
Absolutely.
And that's another little plug, is don't be afraid to get it, because we'd rather know that you have this risk and act on it as a young woman than after you get a cancer. And not only will it be good to know so that we can watch and survey you carefully, but or preventatively remove ovaries or breasts or whatever needs to be removed, but things will be paid for. If you can get breast MRIs in addition to mammograms, that's expensive testing, and you can get it paid for. So it is, I think, always behooves you to know thy enemy, to know what you have genetically now as a younger woman, so that you can prepare and hopefully not succumb to problems. We've been chatting for a good 30 minutes. I'd love to know, Mary Jane, if you have any final thoughts for cancer survivors of any age.
Well, I think that it's, obviously when we started founding this clinic, one of my residents, who's now the chief of the GYN service, GYN Oncology Clinical Service at Yale, when we started this clinic, and she commented to me after spending a few days with me and seeing patients in my office when she was a resident, she said, you see a lot of cancer survivors. Yes, and I'm really sorry they had cancer, but I'm sure as heck glad they're surviving. And her comment was, well, as oncologists, we sometimes don't deal with these kind of quality of life issues. And I said, well, we should. And she said, well, let's fix it. That's how we got started with our program. And, so the key thing is, I'm sorry all these people have dealt with these tumors, but there are great things that we can do. And I'm delighted they're surviving. And let's make it quality survival. I think that's the important thing.
Yeah, I think cancer survivorship shouldn't just be ridding cancer. It should be thriving and surviving. And I think sexual health is part of surviving. I mean, I think having a robust, I'll tell you,
Yes.
one woman said something so interesting to me. She said, I got breast cancer, and my oncologist said to me, well, you should just be grateful that the cancer's gone. That should be your only objective. And she came to me
Yeah.
crying and said, he didn't tell me that when I got this anti-estrogen medicine, it would destroy my vagina. And I'm only in my 40s. And she said, I'm happy and grateful that I've conquered this breast cancer, but I
Right.
feel that the loss of my sexual function to me is as devastating. And she said,
Yeah.
I don't feel that my doctor felt that sexual function was just by the wayside. And we gave her vaginal estrogen. We taught her to use sole source dilators to help stretch and dilate the tissue and help her have less
Mhm.
vaginismus. We
Mhm.
call it less, you know, resistance to penile penetration. We used, in her case, also CO2 laser with the Mona Lisa touch, which helped regenerate the tissue. And she came in again and she was crying again. And I said, oh, why are you crying? And I thought we helped you. She said, yeah, that's why I'm crying. She said, because I feel now like I can live, like I can go forward now and have the
Yeah.
life I wanted,
Yeah.
not just a cancer-free
Yeah.
life, but
Yes.
a
Yes.
quality of life. And I think that's really what you were
Yes.
saying. I love the fact that she
That's
cried at both
exactly.
times. She cried because she was sad, and then she cried that she was happy. And I think
That's fine. You want
any
the happy cries.
yeah, and any cancer survivor will never be free of thinking about the cancer, but they should be
Sure.
free to advocate for happiness, joy, including sexual satisfaction. Why does that have
Absolutely.
to be too
Of
much
course.
to ask? So
Yeah.
so
It's not too much to ask. It's what you deserve.
right. I think so too. So onward and upward. Thank you for fighting the good fight. Thank you for being a mentor to me and one of my heroes. And
Pleasure.
Mayor
Hardly, but
Mayor of Easttown has nothing on Mayor of East Brunswick, in my opinion. I think.
so yes, just remember 8-9 on the turnpike. Keep that in mind.
Oh my God. to the Jersey girl there, who also goes by Madam Ovary. I go by the Vagina Whisperer. You go by Madam Ovary. So we're just a couple of I don't know, silly girls. But at my website, I think everybody knows is princetongyn.com. But Mary Jane can be reached at madamovary.com, which we've put up a couple of times. And we both feel very, very deeply about this. And I'm just glad. I'm glad to have you. So we look forward to part 2. We'll do it again next year when we have more to talk about. Okay.
And more meds, we hope. More
That's what I
opportunities for
mean.
folks to get better.
That's what I mean. So next episode of Gynecology is in 2 weeks. And we're talking about fibroids. And there is actually a lot of cool new stuff about fibroids too, both medications and surgeries and non-surgical procedures. We're doing fascinating, amazing things for a whole other sector of women, and believe you me, they suffer dearly with fibroids. So I'm looking forward to that. And Mary Jane, I'm really looking forward to seeing you in September at NAMS. All right.
Excellent. Excellent.
All
Looking
right.
forward to seeing you.
All right. Have a good night, everybody. Take care. Be well.
Take care, everybody. Thanks, Maria. Take care.